conduction through the X-ray pathway and retrograde conduction through the AV node His-Perkin system, where you get a broad QRS. And about 30% of them can conduct really fast. As all of you know, 250 milliseconds is the cutoff for a dangerous pathway or a high-risk pathway. So about 30% of these patients with manifest pre-excitation have a high-risk pathway. So one more reason why these patients often need an EP study is because of X-ray pathways. So often the X-ray pathways are concealed, and they may have rapidly conducting pathways or multiple pathways, which are a risk factor for sudden death. So if the patient has palpitation or is planned for surgical repair, ideally we should perform an EP study. Same slide which you well showed. So I won't repeat myself. The important challenge here is if you want to ablate an accessory pathway, you have to burn at the annulus. You need an A signal, you need a V signal. It's not very hard. But here, you've got a third signal, which is the signal from the atrialized right ventricle. You've got this fragmented low amplitude signal. So you don't know where the annulus is. Whether if you're not on the annulus, you cannot ablate successfully. You have to keep ablating for a long time unnecessarily. So that's the one challenge these patients have. The other challenge, of course, is like moving the catheters in a big heart. So it's very important to identify the true annulus. And traditionally, it's fluoroscopy, X-ray, and doing contrast injections and taking cine pictures. And then right coronary angiography, because the right coronary artery, as you know, runs in the right AV groove. And then all of us now use electron-anatomic mapping, which is available, where you can, using the help of technology and a computer and some impedance mapping, you can transfer pictures onto a screen. And without using X-rays, you can see see the heart. You can also merge a CT scan. It's hard to merge an MRI in our system because the software is extremely costly, but the CT can easily be merged. And finally, using intracardiac echo. And I'll show some slides. This is not, I use a lot of angiograms. I no longer use it because of the contrast load and fluoro. This is from Dr. Walsh's paper, which you will actually showed. On an angiogram with a lot of contrast, you have to use a lot of contrast, otherwise you won't get a picture like this. You can see the ridge, you can see part of the atrialized right ventricle and the RV. So you know where to ablate. You burn here at the AV group. But this is what I use all the time. It's intracardiac echo. So the intracardiac echo probe is in the right atrium. So you have to imagine, it's for all of you are very familiar with transthoracic echocardiograms and subcostal views and transesophageal echoes. It's a walk in the park for you. It's very, very simple for dummy electrophysiologists. Just moving the catheter up and down, you can see it very easily. So you see the leaflets which are displaced downward, and you can see the true annulus. That's a catheter in between. You can make out where to ablate. Just to show you again what intracardiac echo shows. See, so this here, the CARTO system or the electron-anatomic mapping system allows us to transfer X-ray or fluoroscopy onto the screen. So you have catheters you can see in the background, and you have intracardiac echo too. So here is the true annulus, and that's where you want to ablate. This is a patient with a mid-septal pathway. You mark the His in yellow. You ablate here, and here is the actual attachment of the leaflets. And the distance in between is the atrialized right ventricle. So RA, atrialized right ventricle, to the true annulus, and location of the displaced leaflets. And here you can see manifest pre-excitation, post-ablation, no pre-excitation. The other, like Yuval said, the RA is huge. If you just go with a catheter, it's like trying to put a bucket in a big well. You're not going to reach anywhere. You have to get to the wall. So you need a sheath, but you have to see the sheath too. Otherwise, you'll use X-ray and kill yourself, your colleagues, and the patient. So use electron-anatomic mapping. There are sheaths which you can see and which you can deflect. So here is a sheath, and this is a patient with a redo case referred from elsewhere, right free wall pathway. So you can see the sheath, and then you can get there and ablate. And you see manifest pre-excitation and normal PR and a narrow QRS after ablation. So atriovesicular pathways or Mahem pathways are more common in Epstein's than the general population. It's less common in North America, very, very common in South Asia. But here it's very, very uncommon. We hardly see one a year, unless the patient has Epstein or something like that. So The location, electrophysiology, ablation strategy are very similar in Epstein and non-Epstein patients, harder in Epstein patients because the RA is large. So you need this deflectable sheath. The other problem is that you have to get to the RA free wall and the anterior leaflet is huge. So you can't bend your sheath easily. So it's just a technical challenge, but the acute ablation success rate in all published series is very high. Just need some patience. It's one of our cases. So baseline ECG looks normal. Forget about the intracardiacs. Baseline ECG is normal. When you pace, they develop left bundle branch block. When they have tachycardia, they've got left bundle branch block. And then if you go to the right free wall, you see something like a His bundle on the right free wall. That's the accessory pathway potential. And if you ablate there, you get success. So it's the same for Epstein and non-Epstein. This is what we commonly see, atrial arrhythmias. So that's almost all the patients who get referred to us have atrial arrhythmia, and the prevalence is about 20-21%, and the chance of developing flutter over 10 years is around 20-21%. So commonest type of flutter that we see is typical flutter. That is flutter which is based around the tricuspid annulus and goes through the cavotricuspid isthmus. Can also have scar-related flutter, and a small percentage have micro-reentry or focal atrial tachycardia, often related to surgical scars. So we see the unnatural history of congenital heart disease across the street. Well, you're privileged to see both the natural and unnatural history here. So these are all patients with different types of repair. This is a patient post-cone repair. So on intracardiac echo, we can actually see. So you can see the leaflets have reattached to where the annulus should be. This is the eustachian ridge. The cavotricuspid isthmus is small. So you can see where you're ablating instead of going blind. So this was a patient with cone repair. The other problem is patients with artificial valves. So commonly you see bioprosthetic valves. We have had one patient with a mechanical valve, which is a challenge. And I will show you what the challenge is. So this is a CT scan of that patient. So here's the coronary sinus, and you can see the ostium is pinched, and the coronary sinus is below the mechanical valve. So what happens? These are all Osami's patients, actually, all three patients, which I'm going to show now. And he's not here, I guess. So when the surgeon in order to avoid injury to the conduction system, the way the surgeon stitches is that the coronary sinus may be partly on the ventricular side of the bioprosthetic valve. So part of the coronary sinus and part of the ventricle is on the other side. So you can't reach it easily. You've got a valve in between. So if you see here, the valve is on top of the coronary sinus. If you look at the ECG of this patient, you can't make out flutter. But the patient had a device. On the device, you can see there is flutter. The patient is in atrial flutter, and that's why symptomatic. To do these patients, you have to use fluoroscopy and biplane. You'd use the right view. If you use LAO, if you look from here, you're behind the valve. It's no use. See RAO, you can make out. It's a ball and cage valve. It's very, very hard to see. There's only one patient, which we have seen. And in the Mayo series, there's only one patient. And we found that's actually the same patient in the Mayo series. It's the same person who came here. So if you use right anterior oblique view, it doesn't have to be. You can use some common sense and move the camera. You can stay away from the valve. You don't want to get entrapped inside the ball and cage. So you can pull the catheter out. It's in a disc valve that's really dangerous. In a ball and cage, you can pull the catheter out. Don't want to try it though, but you can. So apologies for the electrophysiology, but basically, see, in this patient, how we do these ablations is that you want to see all the colors of the rainbow crowding around in a spot. So if you see all the colors of the rainbow around the tricuspid valve, you know it's typical flutter. If you see all the colors in the right free wall, you know it is a flutter related to a scar. So this patient, the challenge was, is it around the tricuspid valve or is it around a scar? There's supposed to be a video, which is not working. Okay, that's fine. But how do I make it work? Okay, thank you. So these vertical bars is what's called ripple mapping, and you can see how it goes through. You can see the activation front going through scar on the right free wall, but in the cavotricuspid isthmus seems to stop, then start again. So something missing. So we thought that this could potentially could still be a typical flutter, and there's a hidden isthmus. It's going underneath the valve and then coming back out. Now, how do we prove that? So forget about this busy slide. We use what's called entrainment mapping. Principle is simple. You pace and let go. And if the interval is short, you're close to where the target is. That's the principle. So you pace from different locations, and I'll summarize this. So you go all around the annulus, and you find that laterally, the interval between the tachycardia and the return cycle is very short, which means you're in the circuit. Medially, you're still close, but not really close. So we assumed it's here, and we ablated and terminated it. This is the challenge here is that you got a mechanical valve, and what we postulate is that part of the circuit was on the ventricular side, part on the atrial side, and we managed to hit the exit in between, the connection point in between. And there are other ways to do this. One of the ways is to go through the valve, but you can't do it in a mechanical valve. You can do it in a bioprosthetic valve, and that's been done by other people and by us too. So this is a patient with a bioprosthetic valve. It's again Osami's patient. Again, the circuit around the valve was not complete because we don't see all the colors of the rainbow around the circuit. So we entrain and we think it is here. We go to the left atrium, it's not there either. So we assume that's hidden underneath the valve. So we ablate in the isthmus and we terminate tachycardia. Same thing for this patient. Again, it's the same thing. You don't see all the colors around the tricuspid valve. So is it somewhere else? No, it is here. We entrain and then we ablate and we terminate here. So that's the challenge which Yuval was saying. Once you operate on a patient and put in a valve there, it's hard to ablate and terminate tachycardia successfully. And the common tachycardia these patients have is typical atrial flutter. This is not our case. Uh, People have tried to go through the bioprosthetic valve and ablate on the other side and terminate flutter. Some people have gone into the small cardiac vein, which you know is a tributary of the coronary sinus, which runs in the coronary sulcus, and have tried to ablate there. It's one case report only. And this is heroics. This is a patient who was in the same situation, had a bioprosthetic valve, but the valve was dysfunctional. The patient was planned for a percutaneous valve-in-valve anyway. So the electrophysiologist decided to puncture below, go on the other side and ablate. But that will disrupt the suture valve mechanism. But the valve was going to be changed anyway. Obviously, we can't do that in a regular patient. The other common tachycardia, we see scar-related flutters. It's what I was talking about. If you see all the colors of the rainbow around the scar, you see the activation front going around the scar and the scar-related flutter. You can also see AVNRT, which is a very common arrhythmia. It occurs in about 8 to 13% of patients in one series. The challenge here is that you don't want to ablate the AV node. So you have to stay away from the AV node. The landmarks are usually distorted. And normally, to ablate AVNRT, you want a small atrial signal and a huge ventricular signal. But you're not going to get a huge ventricular signal here. Because of the atrialized right ventricle, the signal will be small. You just have to be aware of it. This is one of patients, a 26-year-old male who had a history of bone repair elsewhere and at monomorphic VT, underwent VT ablation in a different center, but unfortunately had an out-of-hospital cardiac arrest and got this dual coil epicardial ICD. And before coming to our institution, he had 5 episodes in the VF zone with shock, with 1-to-1 AV conduction. There's a suspicion of atrial flutter. He was not ablated. He was given sotalol and aspirin. And then he came to us and we assumed it's flutter. We didn't have access to the tracings. And we induced typical flutter and atypical flutter and ablated him. But he kept having these episodes every month with ATP, no shocks. He will have anti-tachycardia pacing and atrial flutter. And finally, we looked at his device tracings. And on the top channel is A. On the bottom channel is V. A is on top of the V. When you see that, you suspect AV and RT. And at the beginning, you see a PR jump. See, you have an atrial premature complex. My mouse? Oh, I need a pointer, I guess. I'm just pointing in out. No, sorry. So you see an atrial premature complex which initiates the tachycardia. A on top of V. It's AVNRT. So we ablated the AVNRT. During the ablation, you see this narrow QRS tachycardia, which looks like AVNRT, but it's junctional tachycardia, which is the usual response you see. And look at how little space there's between the yellow spot, which is the His bundle system, and the red spot where we ablated. So using electroanatomic mapping, you can measure and see. If you're more than a centimeter, you're usually safe. As our patients grow older, we see more and more atrial fibrillation. In one series, about 11% of patients develop instant atrial fibrillation. And obviously, the prevalence of atrial fibrillation will increase with time. Atrial fibrillation develops at relatively young ages in these patients, and many of them have recurrent atrial fibrillation. And there's a correlation between heart failure hospitalization and atrial fibrillation, and freedom from death and atrial fibrillation. So what do we do in these patients? Atrial fibrillation, as you know, is left atrial disease. So the usual treatment for atrial fibrillation is isolating the pulmonary veins. So there's a series with 2 patients where they did pure RA ablation and managed to get rid of atrial fibrillation. One of the patients had recurrence at 2 years. The other patient still being followed. So we tried that in one of our patients. We did a right atrial substrate ablation, but unfortunately it did not work. She had recurrence of atrial fibrillation within the year. So this is she had an ASD device too. So this is the ASD device on intracardiac echo. So we went ahead and did a pulmonary vein isolation. We punctured below using intracardiac echo. And then we used this new form of energy, which is safer for pulmonary vein isolation, called pulse field ablation. The red is scar, and the purple, uh, what you want, I don't know what color you call this. Well, this color is normal tissue. So this is before ablation, and the idea is to isolate pulmonary veins. So we do place ablation lines all around. These green spots are pulse field ablation. We also isolate the posterior wall. It's quicker. There's less chance of injury to the esophagus and less chance of injury to the phrenic nerve because it's cell selective, this form of energy. So that's how we manage this patient. So how to manage this patient is not clear, but this is our limited number of patients with AFib that we have. Very rare to have ventricular arrhythmias in Epstein's anomaly. The series talks about 8.3%. We hardly see this actually. It's the least common of all arrhythmias. And the anatomic severity of Epstein's anomaly does not really correlate with the instance of monomorphic ventricular tachycardia. Obviously, if you have a dysfunctional RV, then you're likely to have polymorphic VT, which anyone can have. And there's no clear consensus on how to give a patient an ICD, when to give a patient with an Epstein's anomaly an ICD. This is not our patient. This is from Jeremy Moore. So this is an example of monomorphic VT, which they ablated successfully in the atrialized right ventricle. So 2 forms of VT. This is the Traxwood valve, and this is the atrialized right ventricle. And they ablated within the atrialized right ventricle and terminated the tachycardia. This study had one important finding. They found that before surgery, in unoperated Epstein, the ventricular tachycardia is usually based within the atrialized right ventricle. After surgery, it's within the right ventricle, either within myocardium or Purkinje fibers. Okay. Regarding the pre-op EP study, it's in full agreement with you all. So it's hard post-op to do a post-op EP study because you have to go through the valve. It takes longer. There's more fluoro time, lower success rates. If it's an incision-related, scar-related atrial tachycardia, you can ablate it easily. If it's an axillary pathway, it's hard. If it's CT ablation, it's hard. Like I said, you might have to innovate to get to the right side once there is a prosthetic valve in between. If you look at the guidelines, the 2018 guidelines place an EP study as a class 2A indication for patients with Epstein's anomaly. So an EP study can be recommended even in the absence of pre-excitation or supraventricular tachycardia in adults with Epstein. It's class 2A as per the 2018 guidelines. The 2014 ACHD arrhythmia guidelines place this in a class 2B category. How to prepare for ablation? Like any congenital heart disease, obviously you have to read the post-op notes. You have to make sure there's access. You have to be aware there's right to left shunting. So as soon as you get venous access, you have to give heparin because you stand the risk of a stroke on table. And obviously you need some form of multi-imaging, either angiography, right coronary artery angiograms, or intracardiac echo. So just to summarize what I said and what you all said, absence of right bundle branch block in Epstein's anomaly with SVT almost always has the right free wall pathway. These patients may have multiple pathways. There's a higher chance of having atriovesicular or Maheim pathways. Electroanatomic mapping should be used even for simple ablation. Multimodality imaging is important. Slow pathway modification for AV should be performed only after tagging the His signals. Very medial ablation lines should be avoided. And if you have a valve, you might have to do multiple ablation lines to terminate tachycardia. You may not, that'll avoid going through the valve. It'll avoid doing fancy things like puncturing from below the valve. Atrial fibrillation is associated with heart failure hospitalizations. In Epstein's anomaly who have not undergone Traxford valve surgery, the atrialized right ventricle is usually the source for the ventricular tachycardia. And it's reasonable to perform an EP study prior to Traxford valve surgery in Epstein's. Thank you.
Excellent. Thank you, Dr. Nair. I would encourage our colleagues and registrants online to post their questions in the chat forum. Does anybody have any questions in-house? Dr. Friedberg?
Very much. Excellent session. Dr. Nair, my question is for you. You said that the pattern of right bundle branch block is seen because of ventricular enlargement in the beginning of your talk. Can you clarify what causes that? Is it the absence of the right bundle or just that there's ventricular enlargement and the conduction has to travel through a myocardium or?
Yeah. Well, the two reasons that are postulated are one is the right bundle branch itself is hypoplastic as, uh, uh, as a congenital abnormality. And the other mechanism is any RV dilatation can cause some intraventricular conduction delay, but doesn't produce typical right bundle branch block. Those are the two reasons that are postulated for the conduction abnormality that we see.
Thank you. We have a question online from Dr. Dawood, pediatric cardiac surgeon from Pakistan. The first part of the question is regarding adults with Epstein's anomaly, but I think it can be also applicable to pediatrics. So, is a 24-hour Holter adequate to screen for accessory pathways, or would you recommend carrying out EP studies in every single patient with or without palpitations?
That's that's a difficult question to answer. I mean, we have to look at logistics and our resources too. So the data is for the pre-surgical patient, and what we're both talking about is the pre-surgical patient. If a patient with Epstein's anomaly is not planned for surgery, the baseline ECG does not show pre-excitation. What we usually do is do an exercise stress test and a Holter for maybe 72 hours. Or I mean, there's no guideline or data on whether a 72-hour Holter is better than less than a 7-day or a 14-day Holter. But an exercise stress test will usually clarify. That's what we do in a patient who's not planned for surgical repair.
Yeah, thank you, Dr. Nair. And if I may just share and reiterate Dr. Bitterman's uh, uh, point when he made during his presentation is that at least here at SickKids, we're quite comprehensive in our evaluation of Epstein's patients pre-cone. So for the most part, some exceptions being those that are quite tiny, so less than about 2 or 3 years of age or 15 kilos, if an Epstein's patient has no symptoms, no palpitations, no documented SVT, we still would bring the patient to the electrophysiology lab for at least an electrophysiology study. Um, for the main reason being there could be a concealed atrioventricular accessory pathway that can be a substrate for SVT in the future that may not be hemodynamically stable. And as both of these speakers pointed out, accessing that accessory pathway post cone repair can be very challenging. Um, but I actually wanted to kind of challenge that and ask Dr. Yuval if he can share the SickKids experience with that approach. And also wanted to point out the very study that you shared with us, Shivapur's 2013 study, where they brought patients without palpitations and documented SVT, no pre-excitation. None of them had an atrioventricular accessory pathway. They had flutter, they had VT, they had polymorphic VT, but those can all be accessed and managed post-op, either medically or with another ablation. So I'm wondering your thoughts, Yuval.
Yeah, thank you for the question. I think first of all, as you said, we tend to take all of these patients to some form of an evaluation, and even if they're small, we might do an abbreviated study with some atrial pacing, ventricular pacing, maybe one or two catheters using adenosine, and not doing the whole gamut of testing that you might do. I think there are still very much open questions. One would be whether we need to even embark on ventricular stimulation protocols, which we currently do not do. And we we don't really see much VTs in childhood, and they're accessible afterwards. So my preference or thoughts would be that this is probably does not need to be part of the evaluation at the outset. Also because they don't tolerate ventricular pacing and they're very small at that point, and hemodynamically unwell because they're pre the operation. So that's the first point that's kind of open, but I think it's pretty reasonable to not do that. Um, and then the second thing would be to minimize the amount of catheters and interventions if you can for those that do have the classic right bundle. The PR is not very short. You don't have a suspicion that there is an accessory pathway and you just want to make sure that there's nothing else. I think it would be very reasonable to do a very abbreviated assessment, especially in these small children. And then in terms of flutter, quite rare and definitely not the common norm, unlike in the adult population where the stretch has been going on and all the hemodynamic effects have taken a toll. So definitely not something that I would, unless you see it in the lab and it happens and you can address it safely, all of these things are usually not the case, then I wouldn't probably touch that.
Perfect. Thank you. We have another question from the audience.
I have a question related to the electrophysiology. What is known currently about the electrophysiology properties of the right ventricle or and the right atrium in this population? Because we usually look at the echoes and MRIs, like when it comes to assessing the how healthy or how sick the right side is. But what do we know about the electrophysiology really in this population?
Maybe if I understood the question correctly, and it kind of connects to what Dr. Frieder was asking about the right bundle. I think that we have nice evidence from histological studies that there is a myopathy that is associated with Epstein's anomaly. It's not just that the tricuspid valve is abnormal and displaced, but actually that the myocardium is different. There is disarray of the muscle fibers and the cell architecture, and obviously, when you have such a disarray and a myopathy, that also changes the conduction cell to cell throughout. So I think one of the competing theories for the other two theories that were suggested here for the right bundle branch block, but also for the conduction abnormalities, is that it's just the disarray of the actual architecture of the muscle causing issues of conduction also, and not just dysfunction that can be out of keeping with just basically the displacement of the valve. It could be more than that because of a myopathy. And that can affect also the electrophysiological properties. And probably as patients survive into older age, with the help of the beautiful surgical interventions, we will start seeing more and more of these patients develop the same issues that patients that have scarring in the ventricles have, and something that we did not talk about at all, but also would develop more desynchronous activation or incoordinate activation of these ventricles, which will be something that we'll probably at some point will need to also start addressing.
Thank you. And did we come so far that we can even predict it? There are always this kind of attempts to predict how the myocardium will function and how early or late we should intervene. Do we have any studies from the electrophysiological perspective that we can use to predict how the muscle will work in the future?
I mean, that's if you look at ventricular adult congenital heart disease have been classified into two groups based on the type of ventricular arrhythmias that are usually induced. So group one is patients like tetralogy of Fallot, where you have finite scars and critical ischemia and different locations. They are prone to monomorphic ventricular tachycardia. And then there is group two, where it's usually the post-atrial switch patients, the Mustards and the Sennings, where they're prone to polymorphic VT. And in the gray zone, conditions like Epstein's anomaly, where usually they're more prone to polymorphic VT and VF when they develop severe RV dysfunction, but they may also have monomorphic VT from the atrialized right ventricle. So that's how you look at Epstein's anomaly, to have both. So, but I don't think there is a definite risk score or a definite way to predict which patients will develop what in the future. An EP study, if it develops, if you induce monomorphic VT, of course, it predicts events. If you get polymorphic VT, it could just be non-specific and depends on how robust the induction protocol was.
And maybe I'll add another point that there is a study that was presented actually also yesterday that did look at fractionation of the QRS as a measure of risk for future dysfunction. And it makes sense because fractionation is basically the incoordinate activation, the kind of back and forth activation that's disorganized, and that is probably indicative of a ventricle that is more, if you will, myopathic or with disarray or with scars in it if it's after surgery, and would probably indicate that this ventricle is going to be sicker afterwards. I don't think we have clear risk stratifications for these patients. The one last thing that is sort of more of a hypothesis that some people have already mentioned in the past that I would put out is that if we do take all these patients for a pre-procedural assessment and we find accessory pathways, and let's say that they sit on the left, on the right free wall, um, we just have to be mindful that these patients have a narrower QRS duration at the time of ablation before we ablate them. And once we ablate them, we actually take away that pathway. And now they have a wider QRS duration with longer activation through the ventricle. What does that do over time to that ventricle? And will they develop the synchrony-induced cardiomyopathy? We don't know. But probably when we have more adults, longer duration follow-up, we will probably start seeing if that is an issue.
I have a few questions for Dr. Nair, starting with kind of a general question for our colleagues online who are adult cardiologists caring for these patients. How soon should they consider referring to an electrophysiologist for an ablation?
So, well, if the patient has manifest pre-excitation, for sure, because we have to risk stratify and without an invasive, I guess it's a little controversial, but without an invasive EP study, I think it's hard to truly risk stratify an accessory pathway. And if they're symptomatic with palpitation, because it could either be they may have a concealed pathway or they may have atrial flutter. But if the patient is asymptomatic and the Holter and exercise stress are normal and surgery is not being planned, uh, I'm not sure we'll do anything for those patients. If surgery is not being planned, then we'll just do a stress test and a Holter and see them. So
Okay. And then regarding AVNRT, I think you beautifully noted that the triangle of a Koch is really small. They're inferior extensions. And some of our Epstein's patients may have CCTGA or ventricular reversion. How aggressive are you at ablating AVNRT?
so in congenital heart disease, if when we do AVNRT ablations, we are most careful with AV canal defects because because the conduction system will be displaced posterior-inferiorly right near the CS. So if the His bundle cannot be tagged, I'd never ablate. So I have to see a His bundle, else I will not ablate. So that's why. But if I see His bundle clearly, and there's no His bundle where near the coronary sinus ostium, then I would ablate.
Fair point. And then you mentioned the challenges of ablating typical flutter post cone. For that reason, do you suggest that we, before the cone, or our surgical colleagues in the OR do a surgical cryoablation of the CTI line?
That's a great idea, and whenever we talk to our surgeons, we say the same thing. If interventions are being done in the operating room, I think the two things that can be done are obviously doing the CTI line and placing epicardial pacing wires, permanent epicardial pacing wires, so that we don't have to go through the valve if the patient requires pacing later. So those are two things I recommend. Yeah.
So you place empiric epicardial leads regardless of any intraoperative complete heart blocker.
I don't think we do that universally, but it depends on the surgeon too, I guess. But that's what we'd recommend generally, placing epicardial. Whenever interventions are being done on the tricuspid valve, I think it's a smart thing to place epicardial pacing wires. And typically, I would request the surgeon, if there are two ventricles, to place epicardial pacing wires both in the right ventricle and the left ventricle, in case the patient needs biventricular pacing in the future. Yeah.
Thank you. Are there any other questions from our audience? Please.
Well, I just want to congratulate both of you for beautiful presentation. Appreciate it very much. Of course, I have a lot of experience arrhythmia as an older surgeon because I used to do it before people start doing in the and the AP lab. And in Pittsburgh, as you mentioned, sometimes you have multiple uh, abnormal conduction tissues across the annulus, the tracheal valve, and with magnification we can see them sometimes. And it's interesting that especially in small baby, they try to do to ablate it, but if it's too much, it's difficult. They just do one or two parts, and then the surgeon at the OR we see the marker because they say where they are and they have the marker. So we extend that, and we can do it very quickly with the probe, RF probe. And we always do the ablation of the CTI, the cable tricuspid isthmus. And I used to do we do a big incision, the atrium. So I used to connect the end of the inferior part of the incision with the annulus too. And I think those points are important, as you said, to prevent atrial fibrillation. There's one concern doing it in the EP lab when because of the coronary artery, as you mentioned. And sometimes I know that at the beginning they tried to do more than needed because they didn't know about their experience doing it in the OR. So we said that they burn near the right coronary artery. And we took picture of this. It was very nice because we have an interaction with the group there. Now, the question I will ask for both of you, is possible to have a catheter with cryoablation? Because then you might do it extensively. And if you happen to freeze the coronary artery, it will be more a temporary lesion because they open up once you stop the process.
We use cryoablation only in one situation now. It's for two situations. One is for AV and RT because it's reversible. So we can cool we cool the slow pathway down to -30, and if there is no complete heart block, then we go to -60. The other situation for using a cryocatheter is in a free wall X-ray pathway because the catheter sticks. If you don't have good support, it just sticks to once the ice bubble forms, or ice crystals form, it sticks to the wall. Those are the two situations where we use it. The other catheter that's available is the cryo balloon, which we use for pulmonary vein isolation. The problem with using cryo is a 20% chance of recurrence. But you're right, in the CTI, you could use it, and maybe I'm not sure, but there'll probably only be reversible injury to the coronaries. We have not seen that commonly, though. But what is described is that close to the AV ridge, sometimes the ridge paradoxically may be thin in Epstein's patients. And if you burn with high power at the annulus, you might hit the coronary. We have not seen it luckily so far, but it's reported.
What I will say also is that because of that proximity of the coronary to the ridge, it's kind of recognized that you should probably avoid irrigated catheters, which basically create a deeper lesion. So if you are doing RF, you should do regular RF and not irrigated catheters, because then you run a risk of going into that coronary. The one thing I will say is that we don't, as far as I recall, we don't routinely assess the right coronary artery after these ablations. So actually, we probably do not know if there is some sort of a small obstruction that is not clinically evident, at least afterwards. That's a fair point, though.
The other interesting point is when we exclude the atrialized right ventricle, we suture the endocardium, and in order to prevent causing lesion like reentry circuit, and but sometimes we have actually have two cases in our experience that have a lot of arrhythmia. Then we were in the OR, so in Pittsburgh we froze that part, that excluded part, and I mean near the ventricle, at the limit there, we excluded we ablate in that way with cryoablation, and it works temporarily, then come back, but was controlled. So it was resolved. But in São Paulo, we had the patient had ventricular fibrillation many times. Then we suture inside. It was on ECMO. Was hard to there in that setting. It was hard to take to the lab and do differently. So chest was open, and we did with suturing. We eliminate exclude that part as suture, and it worked immediately. It was very interesting. Um, have you had a chance in the postoperative period that you see a lesion that is coming from there, causing ventricular arrhythmia, ventricular tachycardia, for example? Have you seen cases like that in your experience?
Not ventricular, but atrial arrhythmia. We have seen a handful of cases where the surgeon has plicated atrial tissue, and then when you try to ablate, we cannot terminate tachycardia because part of the tissue is sewn in. So you can't get to the circuit. So what we have done, founded by chance, that if you do multiple ablation lines, we can cut off the connections between the hidden isthmus and either side. So that's what we have done for the atrium. Ventricle, I've never seen. Thank you.
We haven't either, but atrial we do see. I will mention, because you said cryo and mentioned cryo, eventually with cryo lesions, you do create cell damage. So it's just a matter of the reversibility during the phase of non-complete freezing that you can stop and everything thaws off. But eventually, if you put the cryo lesion, and especially if you do like we do freeze, so two lesions, one after the other in the same spot, you create a deeper lesion, and you could create damage to the coronary anyways when you're doing it.
I think it's going to be interesting to see how the field of electrophysiology evolves now with the emergence of a new ablation technique, pulsed field ablation, which is non-thermal. As Dr. Nair said, it targets specifically cardiac tissue and avoids damage to like phrenic nerves and other non-cardiac tissue. And I think it's going to be interesting to see its use in other arrhythmias, particularly in perhaps the atrialized RV, where it's a little bit more sensitive. Um, Thank you, everyone, for this very rich discussion and sharing your insights. I think it's a nice example of how dangerous it is to put an EP lecture just before lunch, because we can talk forever about arrhythmias. So thank you both to our incredible speakers for your attention here. We are now in the lunch period, and we'll see you back at 1:15 for the next session. Thanks, everyone.
Okay, good afternoon, everybody, and welcome to the next session, which is entitled Advanced Therapies, Cardiopulmonary Function and Extracardiac Considerations. So we're going to start with a case presentation by Dr. Jasmine Nari. Dr. Nari got a medical degree from Western University and is currently undergoing fellowship training in adult congenital heart disease at the University of Toronto. Thanks. Thank you, Dr. Nari.
Great, thank you for the introduction. So we'll start off the session with a case presentation, and full disclosure, I am adult trained and doing my training over at TGH, but no other conflicts. So we start off with our first case presentation. It's 2019 and the patient is transitioning to another cardiologist. It's a 60-year-old female with an Epstein anomaly of tricuspid valve with severe TR. She also has a PFO and there's a chronic pericardial effusion. From an arrhythmia perspective, she's had WPW with radiofrequency ablation in 2008, and there was SVT during an exercise stress test in 2012. She was offered ablation multiple times, but had declined every instance. And then in 2016, there's an episode of non-sustained VT. Other than that, she had a thalamic stroke in 2017, but had full recovery without any residual deficits and also had diabetes mellitus. At that visit in 2019, the patient tells us that she's noticed a progressive decline in exercise capacity. She can still climb up to 2 to 3 flights of stairs, but is short of breath after that, and still can do chores at home and volunteer at a food bank. When we examine her, height and weight are baseline. Blood pressure is stable, 126/82, and there's a 1 out of 6 hollow systolic murmur at that point at the left lower sternal border. But lungs are clear, there's no ascites, there's no hepatosplenomegaly on exam, and no peripheral edema. When we look at her ECG in clinic that day, she's in sinus rhythm. There's biatrial enlargement and right axis deviation. And then we go ahead and get a chest x-ray. On the PA lateral, we see that there's cytosolitis, levocardia, and cardiomegaly, but notably no previous sternotomies or thoracotomies. And of course, we go ahead and get an echo. And what's important to note of our transthoracic echo at that visit is that she still has good biventricular systolic function. We note again the severe TR is expected on this echo, and apical displacement of the tricuspid valve leaflet demonstrated nicely by the sonographer here of 2.9 centimeters, and that residual chronic small pericardial effusion. But we're pleased in the fact that her biventricular function is preserved today. So we go ahead and get a CPET, and notably her VCO2 at anaerobic threshold is extremely elevated at 60. The O2 max is only 49% predicted. On respiratory exam, there's some moderate restrictive lung disease and a bit of an obstructive component as well. But remember, she has that PFO and she doesn't desaturate on this test. Baseline oxygen is 95% and it's preserved throughout. So we have a 60-year-old female with subjective and objective evidence of decreased exercise capacity and preserved right and left biventricular systolic function. There's severe TR. So we initiate a surgical discussion, but this patient is quite resistant and she declines any intervention. She goes on her way, and we follow up again with her in 2 years. So it's now 2021, and our patient's 62 years old, and she comes back to clinic symptomatic. She says, I'm tired with activity. It now takes her a full day to complete these household chores, is what she's noticing. And she also describes exertional chest tightness. In addition, she has some palpitations and presyncopal symptoms. Now she's open to discussion of surgical options. So we have to add on to our workup. We go ahead and do a right and left heart cath and a coronary angiogram. Fortunately, on the coronary angiography, there's no obstructive coronary disease. There's a bit of a concern for an LAD lesion, but they do IVUS and FFR, and the lesions are non-significant and not for intervention. From our hemodynamic perspective, her RAP is only 6 millimeters of mercury, and her wedge is 10 millimeters of mercury, but output is low. This is her output, not her index, and it's 2.97 liters per minute. And then we go on and repeat her CPET. Initially, we thought that things are a little worse. Her O2 pulse is now 49%, but her VCO2 has improved slightly, and her VO2 max is a little bit better. So we represent our patient at our multidisciplinary case conference. We are proposing tricuspid valve replacement. Those in favor feel that if we have a TVR, we would increase preload and thereby improve her cardiac output. But there's a lot of people that are concerned in our meeting. They worry that a tricuspid valve replacement would pose a risk of diastolic dysfunction and decompensation requiring a VAD. Overall, there's concern that this patient wouldn't wean from cardiopulmonary bypass in the OR, but nonetheless, we refer her for surgical consultation. Despite being open to that discussion, she declines and doesn't actually go ahead to the appointment, and she's lost a follow-up for about a year. So in between all of that, we see her again next in 2024. Our patient's now 65 years old, and she was just too afraid to come back to clinic because she was afraid of surgery. She has progressive decline in exercise capacity to the point that she can now not complete any of her household chores. She lives with her mother and sister, and they're doing everything for her. And so this patient is electively admitted for cardiac workup. We proceed with a cardiac MRI, which demonstrates severe dilation of the right ventricle. And diastolic volume was 639 2 years ago. It's slightly increased, but what's striking is the increase in our end systolic volume, over 100 milliliters. And that's what's led to a reduction in our stroke volume and our EF. But what's more, we're seeing a reduction in the left ventricle as well. Our stroke volume is only 35 mils with reduction in LVEF as well. So we're now concerned about biventricular systolic dysfunction. We repeat the echo, which demonstrates essentially torrential TR here. And we re-demonstrate that small pericardial effusion. But her cardiac function is a little bit worse than it was, and her right ventricular systolic function is certainly worse than it was before. So we'd like to get a better assessment of her exercise capacity, and we have her repeat a cardiopulmonary exercise test. This time, she's only able to exercise for 7 minutes. Her O2 pulse is strikingly reduced, as is her VO2 max, and in fact, she can't even reach an aerobic threshold during this test. And for the first time, her oxygen saturation drops during the test. So before, we didn't have any issues with shunting, and now she's shunting through the PFO during exercise. So we bring this patient forward for a multidisciplinary case discussion. We have a 65-year-old with deteriorating right ventricular systolic function and severe TR with Enstein, with objective progressive decline in exercise capacity and symptoms that match it. But the opinion is that right now the patient is considered too high risk for tricuspid valve replacement, and instead there's a recommendation for cardiac transplant assessment. So we go ahead and admit the patient to hospital for right ventricular dysfunction. Right off the bat, she goes ahead and is started on milrinone therapy. Unfortunately, over the course of this admission, she develops recurrent episodes of atrial flutter. With each instance, there's further decompensation. It consists of hypoxia as well as insults, both renal and liver, and she requires initiation of therapy with amiodarone and repeat electrical cardioversions. Finally, she requires an urgent inpatient ablation one day, as we just can't cardiovert her at that point. And fortunately, the ablation is successful. She's very fortunate because the next day she actually had an offer and she was successfully transplanted. And so overall, from admission for the milrinone therapy to transplant was a 2-month hospitalization. So this was a case of a 65-year-old patient with Enstein anomaly who actually had surgical discussions first initiated 25 years ago, and she has declined decisions at every point in time. But what was important in her case was that we had serial monitoring with CPET, and we demonstrated objective decline in exercise capacity. And in fact, the CPET demonstrated a decline before she was even very symptomatic. And that's what helped us to determine timing of surgical repair. For this patient, by the time she agreed, surgical valve replacement options were exhausted, but she was fortunate that she was a successful cardiac transplant candidate. Thanks.
Okay, thank you very much, Dr. Nari. We'll leave all the questions till the end of the session, but if you can sit wherever. So Dr. Nick Fitzgerald was meant to speak next. However, there's been a family emergency, and so he won't be speaking today. However, the slides from his presentation will be distributed in the coming days to everybody. And so next up is Dr. Barbara Sifra. Dr. Sifra completed her residency in sports medicine in Rome, Italy, focusing on her training in cardiology and exercise physiology. She's the director of the exercise medicine program here at Sick Kids and the lifestyle medicine program at Toronto General Hospital. Both of these programs emphasize a personalized and patient-centered approach, tailoring exercise interventions to meet the unique needs and circumstances of each patient living with congenital heart disease. So thank you, Dr. Sifra, for speaking today.
Hello, everyone. Thank you for introducing me, Alison. It's a pleasure to be here. Interesting case. I would have loved to be part of the discussion at the first CPET, probably. So we're going to talk about cardiopulmonary testing and exercise medicine. I have nothing to disclose. As we all know, exercise testing and specifically cardiopulmonary testing is an essential tool for the evaluation of functional capacity and longitudinal management of patients with Enstein anomaly. The test provides valuable information on the physiological limitation of multiple systems, so the cardiovascular, the pulmonary, the if I point, you don't see it, right? Okay, then there's oh, it's okay. I can just do it without. And muscular and nervous system that may affect our patient's capacity, exercise capacity. But CPET offers several additional advantages beside identifying patients with exercise intolerance. And first is risk stratification, which is a primary utility in absent patients. The tests provide valuable information, as we heard, on heart rate and hemodynamic response and arrhythmia risk with exertion. It also offers insight into treatment response, whether we are prescribing medication or structure exercise program, and is also, as we heard, an integral part of surgical decision-making. Lastly, but not less important, cardiopulmonary testing plays a key role in defining appropriate activity recommendation, ensuring that patients remain active while minimizing health risk. And in the case of Enstein patients who develop exercise intolerance over time, it can guide exercise intervention early. So cardiopulmonary testing provides multiple metabolic data that can indicate whether exercise intolerance is primarily due to cardiac and/or pulmonary limitations or impaired oxygen delivery. This table summarizes the cardiopulmonary testing parameters that are most commonly used in clinical practice. The one that I highlight with the red arrow are the parameters that are mostly used for exercise prescription. The one in blue can be used to assess and monitor progress during an exercise intervention. This is a table that summarizes the CPET findings specific in Enstein patients. Peak VO2 is often reduced, as we heard, based on normal values. However, some patients can have a normal exercise capacity. Chronotropic incompetence is very common. Blood pressure response can be normal or reduced. Peripheral oxygen saturation is normal if without the presence of shunt or elevated right-sided pressure, the VE/VCO2 slope is elevated. There are several factors that limit exercise tolerance in Enstein patients, but nonetheless, exercise therapy can increase peak oxygen consumption. And when assessing congenital heart disease patients in general functional capacity, we must consider the wide spectrum of expected peak oxygen consumption values, which vary based on the underlying cardiac lesion and physiology. As you can see here, Enstein patients fall in the low spectrum of exercise capacity, and they're only higher than the single ventricle population. However, this consideration raised two important questions. Is it appropriate to interpret their cardiopulmonary testing result using reference values from healthy individual? And by doing so, do we risk underestimating their true functional ability? So standard normative values, as we know, are based on healthy population data, but congenital heart disease patients, including Enstein patients, often have adapted physiology. So comparing them directly to healthy control may not provide an accurate picture of their actual functional capacity or potential for improvement. And in this study, they actually addressed this point and challenged the way we typically use cardiopulmonary testing result to define a patient's exercise capacity. So what they propose, instead of relying solely on normative data, then we can have individualized benchmark, considering the age, gender, lesion-specific expected VO2 peak ranges. This might provide a more accurate and meaningful assessment in many congenital heart disease, including Enstein patients. And while we haven't yet agreed on standardized approach for this, important to exercise caution when labeling reduced exercise capacity in our patients, and this might be the next challenge in optimize the care that we provide to this patient. As we heard also, cardiopulmonary testing has a very prognostic significance. So reduced exercise capacity typically indicates impaired cardiovascular function and is often associated with an increased risk of morbidity and mortality. And for absent patients, as you can see here, a peak VO2 reduction around 60% of predicted is associated with a high risk of death, hospitalization, and surgical repair follow-up. Therefore, probably serial testing plays a crucial role in monitoring changes in exercise capacity over time, and the previous case actually showed that. So HADL guidelines recommend to perform a cardiopulmonary testing every 1 to 3 years based on physiological stages. So serial data can help identify subtle changes before symptoms or clinical signs become apparent, allowing for earlier intervention and management to further prevent the deterioration of patients' condition. However, cardiopulmonary testing, as any other test, present with some limitation. While it is an excellent tool for differentiating between central and peripheral alteration, it might not always offer insight into the cardiac determinants of exercise intolerance. In other words, cardiopulmonary testing may not provide information on how underlying LV and RV dysfunction, LV-RV uncoupling, and hemodynamic gradients contribute to exercise intolerance. So maybe combining cardiopulmonary testing with exercise stress echo can provide data to better understand the pathophysiology of exercise intolerance in absent patients. At present, there is no standardized method to perform this methodology, no data in pediatrics or adult congenital heart disease. But this combined methodology has been used in adult cardiology, and it offers a simultaneous collection of data from a regular exercise test, an echocardiography, and a cardiopulmonary testing. And so this methodology can be the future for advancing our medical evaluation and management of absent patients in light that this lesion is not only a valve disease, but is a myopathy affecting both ventricles. So what is next in terms of using exercise data? I think next is to use them not just to assess exercise capacity, but also to use that within the lens of exercise medicine. We do know that there is a decline in exercise tolerance, which is more pronounced in childhood and adolescent patients. And so the implication to me is clear. Without structure follow-up, these patients might silently drift into higher risk categories, missing key opportunities for intervention. So the next challenge, I think, is health optimization. And this can be achieved through lifestyle medicine. Lifestyle medicine is something that it's widely now mentioned in adult cardiology. It's a medical specialty that uses therapeutic lifestyle intervention as a primary modality to treat chronic condition, and is based on 6 main pillars. And physical activity is one of those. The goal is to reduce the cardiovascular health burden in adult patients. And I truly believe that we should start using this type of personalized lifestyle medicine in the management of our patients. And we can do this by creating programs that are specific for congenital heart disease patients. And those programs should be based on expert consensus statement, competitive sports participation guidelines, and current evidence on the benefit of exercise for CAGD patients. But unlike cardiac rehabilitation programs for adults with atherosclerotic disease, where the goal is to rehabilitate, the goal of this program should be to promote health optimization through exercise. And the rationale behind building such program is to start approaching exercise prescription the same way we approach any other medical therapy. We will never prescribe a medication without being specific about the reason of our prescription, the dose, and the mode of drug administration. And we should do the same with exercise. And in the case of our patients, if restriction apply, we should look at restriction and promotion as two sides of the same coin, with the type of exercise and the intensity of the activity playing the main role in the exercise prescription. So I mentioned type of activity. There are many classifications published, but I really like this one because it can help us think about pressure load or volume load. So activities in this specific classification are based on static and dynamic component. The increasing in dynamic component is defined in terms of the estimated percentage of maximal oxygen uptake that is required to perform the activity, and it results in a volume load. The increasing starting component, which is resistant training, is estimated as percentage of the maximal voluntary contraction and result in an increase in blood pressure load. So the green zone represents the lowest total cardiovascular demands in terms of cardiac output and blood pressure, and the red is the highest demand. So the other zone depict the low, moderate, moderate, and high moderate total cardiovascular demand. We always also remember that there is no one sport that is pure dynamic or pure static. So we need to really start thinking about what is the pressure load or the volume load that we are prescribing to our patient. The second key component is intensity, and this has to be accurately defined in an exercise prescription. This is a study from our group that summarizes how different intensity level can be defined and incorporated into a personalized exercise prescription for congenital heart disease patients, and it covers both aerobic and resistant training. For aerobic training, intensity is traditionally categorized into 3 levels, and several methods are available. However, if you look at the first 2 methods that are mentioned in the slides, they are based on heart rate. So these 2 methods might not be reliable for patients on medication affecting heart rate or with chronotropic incompetence. So using the Bohr scale can offer a more suitable option, but after those patients, they need to be guided on how to properly assess their effort. And so cardiopulmonary testing result can overcome this limitation of having to rely just on heart rate response alone, and when combined with the Borg scale recommendation can increase the efficacy of our prescription. And again, if you can see here, we can identify 3 levels of intensity that can guide the specific prescription for patients with Epstein anomaly. And the first step towards an individualized exercise prescription is an individualized risk assessment. We need to shift our attention from the type of activity, and we should look more at the person who will perform the activity. And we should start looking not just at the anatomical lesion, but at the single patient's functional capacity, as patients with the same lesion may present with different exercise capacity. So patients should be stratified as proposed in this study based on a comprehensive medical evaluation. So their medical history, presence of symptoms of rest or during exercise, ventricular function, presence of arrhythmia, exercise capacity. In the pediatric age, I would also say motor skills. And this evaluation can help identify 3 levels of risk, as you can see in the slide. And these 3 levels of risk, they can relate to 3 levels of, they can guide our exercise prescription in terms of prescription of dynamic or static component. And although data on the specific effect of exercise intervention on absent patients are scarce, this statement reassures us that exercise is not an absolute contraindication, and some patients with absent anomaly can also participate in competitive sport. As kids, we launched and have the privilege to run the exercise medicine program. This is a program that was built on current models of adult cardiac rehab adapted to pediatric patients. The scope of creating such a program was to better understand whether incorporating lifestyle counseling and exercise prescription in the standard patient care would improve health outcomes and quality of life. As you can see, it's a 6-month program with a hybrid model. We have 2 in-person visits at the beginning and at the end of the program, where we do a comprehensive medical evaluation, including cardiopulmonary testing, a questionnaire for the quality of life. We do body composition, we do an exercise counseling, and a strength assessment. And then patients are followed virtually. We also offer group classes divided by group age, and we have our YouTube channel with personalized exercise videos for our patients. So I want to conclude with a case that was referred to the program, a 16-year-old male with Epstein anomaly. You can see that he presented with severe apical displacement of the septal leaflet with a mild to moderate TR. He had a mildly reduced RV systolic function, an hypertribeculated LV with preserved systolic function, and a PFO with the shunting left to right. He had an excellent cardiopulmonary testing. It was a maximal test with no chronotropic incompetence, good hemodynamic response, no arrhythmia were observed during exercise, and no desaturation. He presented with a normal working capacity and exercise capacity. And Also, the author confirmed that there was no significant arrhythmic risk, but he was sedentary, so he was referred for an exercise counseling. So if we want to apply the approach that I previously presented, we actually placed him in between these two levels of risk. The reason being that he was asymptomatic with no desaturation, but he had an excellent exercise capacity, but he had a mild RV dysfunction and a mild to moderate TR. So the recommendation that we provided was a moderate static and dynamic component activities. And this is an example of the first exercise prescription that the patient received. As you can see, we used the result of the cardiopulmonary testing, but also the Borg scale. So in conclusion, I truly believe that CPET provides a reliable measure of exercise capacity in these patients and has a significant diagnostic and prognostic ability. Serial testing beginning in childhood can reveal abnormalities associated with poor outcome and enable early treatment. And for early treatment, I don't just refer to surgical treatment, but also exercise intervention. There is no evidence currently the exercise is detrimental for these patients. And I think cardiopulmonary fitness can be optimized with exercise therapy if it's timely utilized. And definitely there is a need for a personalized exercise prescription. But there is some still work to do. As I mentioned, maybe combining cardiopulmonary testing with exercise stress echo can be a way to better evaluate patients and understand the pathophysiological limitation of exercise in absent patients. And then considering that the rate of decline is more pronounced during childhood, I think we should understand what is the best method to optimize exercise capacity in this patient, and what are the best metric to evaluate the physiological adaptation to exercise. We also have to remember that health optimization is a behavioral change. And so we need to explore strategies to promote sustainable change, particularly in pediatrics. And also how to use technology and gamification in pediatric for remote monitoring and for increased adherence to exercise plans. And I thank you for your attention.
Thank you very much, Barbara. Okay, so the last speaker in this session will be Dr. Mike Seed, who will be talking on the subject of neurodevelopment. Dr. Seed went to medical school at the University of Newcastle upon Tyne in the UK, where he undertook pediatric training and then radiology training in the UK before moving to Canada, where he trained in cardiology. He's been a staff at Sick Kids since 2011 and our division head since 2017. His research is mainly in fetal and infant circulatory physiology and brain development. Take it away, Dr. Seed.
Thank you very much. So there's relatively little data available about neurodevelopment in Epstein anomaly, but what there is suggests that this might be cause for concern. And I'm going to try and persuade you that data collected on other types of congenital heart disease can likely help us understand why that might be. So this is the updated American Heart Association's statement on neurodevelopmental outcomes in congenital heart disease. And one of the important developments in this field between the prior statement and this statement has been the creation of a registry, which is collected by the Cardiac Neurodevelopment Outcomes Collaborative from thousands of patients across North America. And this preliminary analysis of the first batch of data shows the Bailey scores of infant development collected at less than 3 years of age for the cognitive, language, and motor domains. And with the scores here divided between syndromic patients shown in the red and non-syndromic patients shown in the blue, and then divided by cardiac diagnosis. And what you can see find a pointer, is that Epstein patients that are treated with single ventricle palliation are scoring significantly lower than those with transposition of the great arteries, which of course is a form of congenital heart disease that historically has been associated with a relatively high prevalence of neurodevelopmental problems. And what this registry data has also revealed is a number of risk factors for adverse neurodevelopmental outcomes that include low birth weight, male sex, older age at initial surgery, prolonged hospitalization and the need for multiple interventions, as well as a lower educational level of the primary caregiver. I think what it's difficult to appreciate from registry data like this is the underlying pathophysiology and neurobiology that, that is responsible for these adverse neurodevelopmental outcomes. And one of the major breakthroughs that has been made in that respect, it was the demonstration or the discovery of the fact that infants with congenital heart disease exhibit evidence of delayed brain development at the time of birth and even before they've undergone any treatment. And of course, that implies that the origins of neurodevelopmental issues in patients with congenital heart disease lie in the prenatal period. And this was actually anticipated to a large degree by pediatric cardiologists who speculated that the abnormal connections and obstructions to blood flow that characterize congenital heart disease would disrupt the normal oxygen transport in the fetal circulation to the developing brain. And with new MRI technology, we've been able to confirm that that is indeed the case, that the blood in the aorta, ascending aorta and aortic arch that is supplied to the fetal brain in all of these common forms of cyanotic congenital heart disease is desaturated compared with normal controls. And the response to that in terms of cerebral blood flow appears to vary by the cardiac diagnosis. So in transposition of the great arteries here, which in the setting of a normal cardiac output, there's actually an increase in SVC flow. And this is in keeping with the concept of brain sparing physiology, whereby there's cerebral vasodilatation in response to hypoxemia that helps to preserve cerebral oxygen delivery. But in Enstein anomaly, in patients with severe forms of Enstein anomaly, cerebral blood flow is actually reduced. And this apparent failure of cerebral autoregulation is probably a result of the significant reductions in cardiac output that we have been discussing in patients with Enstein anomaly. Those hemodynamic changes also impact umbilical blood flow, and this, of course, impacts overall oxygen delivery to the fetus, which in turn then is associated with impaired fetal growth and development. So newborns with Enstein anomaly have reduced birth weight and reduced head circumference compared with controls. And Lindsay showed some of these diagrams of the fetal circulation yesterday, that in which the flows are indicated by the numbers in the circles, expressed here as percentages of the combined ventricular output, so the combination of ascending and main pulmonary artery flow. And their oxygen saturations are indicated by the color coding. And so, as we've discussed, in more severe forms of Enstein anomaly and tricuspid valve dysplasia, it's the left ventricle that's responsible for perfusing the whole circulation, including the lungs that are actually perfused retrograde via the ductus arteriosus with a reduced amount of blood flow. And this presumably accounts for the underdevelopment of the pulmonary arteries that can be such a problem for their postnatal management. And when the Enstein anomaly is complicated by circular shunting, we see that the proportion of the left ventricular output that is delivered to the systemic circulation actually drops because much of that LV output is being stolen back into the circular shunt. And if we look at these fetal flow measurements now in absolute measures of flow indexed fetal weight, we can see that in the setting of a circular shunt, although there's an increase in left ventricular output, this doesn't compensate for the reduction in systemic blood flow. So we see a reduction in SVC flow, so cerebral blood flow, descending aorta, and placental blood flow. And those reductions in SVC flow are strongly correlated with reduction in brain growth, in brain weight that we can also measure. So both reductions in SVC flow and cerebral oxygen delivery. And these changes in prenatal brain development predispose these infants to brain injury in the postnatal period that that has a pattern that is much more characteristic of preterm infants. So intraventricular hemorrhage, intraventricular hemorrhage, and white matter injury, as well as the strokes that are not uncommon as a result of right to left shunting. And what we also see on these postnatal brain MRIs is evidence of delayed brain maturation, including sort of simplification of the cortical folding pattern, and a generalized loss of brain volume that manifests as increased cerebrospinal fluid spaces with sort of squaring off of the lateral ventricles. And these brain injuries seem to occur quite commonly in patients with Enstein anomaly or severe tricuspid valve dysplasia, and to some extent independent of the severity of the heart disease or the type of treatment that the patients undergo. And these neuroimaging findings also then translate to delays in neurodevelopmental milestones, here again measured at 18 months with the Bayley scores of infant development. And here we certainly seem to see an association between the severity of the hemodynamic compromise indicated by the sick kids score here, where a higher score indicates a more severe phenotype. Such that 6 out of 8 of these patients that underwent neurodevelopmental testing had evidence of global developmental delay. And here are the test scores indicated as percentiles. And so most of these patients are at least a standard deviation below the mean, and at least one patient is actually more than 2 standard deviations below the mean. And these kinds of early scores on developmental testing tend to predict subsequent long-term problems with neurodevelopment, including learning disorders. And when we look at these patients in the context of other sorts of congenital heart disease, we can see that Enstein anomaly is still a lesion that's associated with relatively high mortality, more so even than hyperplastic left heart syndrome. And we can see that systemic blood flow in the prenatal period is actually associated with postnatal survival, while cerebral blood flow and oxygenation are associated with neurodevelopmental outcomes at 18 months of age. Here, both in terms of SVC flow with cognitive, language and motor development, and cerebral oxygen delivery. But it can be hard in congenital heart disease to separate the relative importance of prenatal influences on brain development against their postnatal course. And in an attempt to study the relationship between postnatal cardiovascular physiology and neurodevelopment, we performed serial brain and heart MRIs in a cohort of single ventricle physiology versus transposition patients undergoing a neonatal arterial switch. The single ventricle patients here are shown in pink and the transposition in blue. And we measured a variety of hemodynamic parameters and some measures of brain development. So what you can see is that following the arterial switch, the arterial saturations in transposition patients come up dramatically. By contrast, transposition patients are more anemic after the operation and at follow-up than the single ventricle patients. And that increase in hemoglobin concentration actually helps to offset the ongoing cyanosis in the single ventricle patients and the lesser increase in cerebral blood flow at follow-up to maintain cerebral oxygen delivery in these patients. And I forgot to mention that we performed these 3 scans at the preoperative, postoperative, and follow-up period at 4 months of age. But what's interesting is that in the setting of normal cerebral oxygen delivery, the single ventricle patients have reduced cerebral oxygen consumption. And that is then associated with failure of brain growth in these patients. So whilst the transposition patients are actually showing evidence of catch-up in brain growth at the follow-up scan, the single ventricle patients have a gradual decline in the brain weight Z score. But it's not just their brain weight, their body weight is also diverging. So that whilst the transposition patients are gaining weight, the single ventricle patients are falling further behind. And this is certainly in keeping with the feeding intolerance that we associate with single ventricle physiology in the interstage period. And it's presumably being driven by this decline in descending aortic flow. So in the setting of a palliated single ventricle circulation, the one ventricle is having to share its output between the brain, the lungs, and the rest of the body. And it's the lower extremities and presumably gastrointestinal tract that get sacrificed to some point. And so nutrition is potentially a part of the abnormal brain growth that we're seeing in the single ventricle patients. And that abnormal brain growth is associated with neurodevelopmental outcomes. So whilst the transposition patients are getting normal scores on their cognitive language and motor testing at 18 and 36 months of age, the single ventricle patients are at least are about a standard deviation below and highly statistically significant. And when we looked for associations between the hemodynamic parameters and the subsequent neurodevelopmental outcomes, we found several parameters that were associated, including cerebral blood flow, hemoglobin concentration, superior vena cava flow, and pulmonary blood flow. So it certainly would appear that postnatal cardiovascular physiology is having an ongoing impact on neurodevelopment, and that this may be at least in part through cerebral blood flow. So I'd like to spend the last couple of minutes just thinking about cerebral blood flow in small children. And of course, this is one of the physiologic parameters that is tightly auto-regulated, so that cerebral blood flow is maintained at a stable level despite changes in cerebral perfusion pressure, which is of course mainly determined by blood pressure and central venous pressure. But with when you reach a certain threshold of cerebral perfusion pressure, that cerebral blood flow will start to drop until it reaches the critical cerebral closing pressure, at which point cerebral blood flow ceases. But what this plot nicely shows is that that relationship between cerebral perfusion pressure and cerebral blood flow actually changes over age. And so cerebral blood flow actually increases during early childhood and then drops down again to some extent during adulthood. And so we can see on this plot that dramatic increase in cerebral blood flow that occurs over the first 6 months of life, postnatal life, that is in some respects following this increase in systemic blood pressure, but largely driven by this drop in cerebral vascular resistance that's occurring at the same time. And this increase in cerebral blood flow is actually matched by an increase in cerebral oxygen consumption. And so this reflects increasing metabolic activity of the developing brain during this period that is an indicator of the increased neurophysiologic activity of the brain. But it's also, to some extent, matching the tremendous growth that is occurring in the brain, that is beautifully shown by this autopsy data, human autopsy data, more than 100 years old now, 50 years old now, that shows this period of dramatic brain growth that starts in humans in the 3rd trimester and continues during the first 18 months of life, such that by 2 years of age, the human brain has reached 75% of its final weight. And just contrast that with body weight, which of course is steadily improving over the whole of childhood. So perhaps brain development in congenital heart disease reflects a unique coupling between cerebrovascular physiology and the availability of resources in the setting of abnormal cardiac physiology and brain development. such that there's some conservation of energy going on in the brain that likely is present to protect the brain from being exposed to ischemic injury or energetic collapse. So I'd like to finish by suggesting that Enstein anomaly is really presenting us with an opportunity to learn a great deal about the relationship between heart disease and neurodevelopmental outcome, because these patients so often exhibit hemodynamic compromise. And it's likely that as more and more of these patients survive, an important aspect of their care is going to be around their neurodevelopment. But it's also an opportunity for us to develop neuroprotective approaches to their management, like closing or restricting the ductus arteriosus in utero to diminish circular shunting, or potentially even converting them to biventricular circulation earlier in life. Thank you very much.
Well, thank you very much, Mike. So, I think we've got some time for questions before we have our next break. If anybody, I'll just move over to the chat. Okay, so Nina at the back has a question.
I am impressed by the talks, and I have a question related to the exercise prescription, and especially exercise, like how do you maintain this exercise prescription for kids to be motivated to do it even beyond this 6-month period? Because what I find challenging at our institution is to, after this excitement at the beginning, to really maintain their lifestyle over time as a more like lifelong approach.
It's an interesting question. As I said, the future is strategies on how to enhance behavioral change. What you're talking is behavioral change. So at Sick Kids, what we're trying to do, we don't have the perfect answer for this, but we do a family exercise counseling. So we're trying to integrate the parents and siblings into the plan or the exercise plan. We also try to explore the activities that the kids prefer, and because of the setting of the program, every exercise prescription is done in their home setting. So I think that if you have, and I don't know which model you have in Sweden, but if you bring the patients to the hospital, you train them for a certain amount of time, you have an increase of many parameters like CPET, strength, quality of life, all of that you can measure. But when patients are then going back to their home setting, then they're missing, the patient, the person that motivates them. So I think one of the things is, one, adapt the prescription to their home setting. And two, I think with this program, we should have specialized expertise. To me, it's sports psychologist, and so motivational interviewing for adolescents and different methods to motivate behavior change. That's the future, but I cannot tell you if there is one way that definitely works. Definitely including the family, it's one metric of success.
Just before we go to the online question, just following up on that, Barbara, I mean, what do you think the future is? Because I was looking at your data, and the data, I really like the concept of not saying that these people with congenital heart disease are necessarily have reduced capacity, because I think that in itself is a negative connotation. And then I was looking at the data that you presented, which was single center data. I mean, do you think in 2025 there's a possibility of making this data set larger in some way through either and either using AI or just how we connect with everybody these days online through an app, getting all the data that from this kind of rare condition, and somehow doing it. I mean, the concept of your virtual clinics, I think, is fantastic, because it really takes the burden off the patient coming into hospital. And I just wondered whether it would be possible, what your opinions are of kind of connecting all of these people around the world with Epstein's and actually getting really great comprehensive data that can be applicable everywhere.
Yeah, you basically give me the answer. So yeah, the answer is multi-center study, especially considering that this is a very rare congenital heart disease. So a single center case study will be limited by the number. So definitely we need to connect that. In terms of the future of exercise program, I like to call it cardiac fitness program and not cardiac rehab, as I mentioned, because we're not rehabilitating them. We're actually empowering patients to live to their maximal capacity. I think the technology can help us connecting center and developing a more standardized way on how we evaluate their exercise capacity, how we evaluate their strength. We're in pediatrics, we need to take into consideration motor skills. We need to take in consideration their motivational level. So yes, AI, multi-center studies, this is the future for this field. Like, we still don't have the answer how to optimize also the exercise capacity. So, I mean, to me, the sky is the limit in this field. So absolutely all the things that you mentioned can be a future direction.
Great answer. Thank you. I think Scott Soifer has a question. At least he has his hand up online. There's nothing in the chat. I don't know if you can put something in the chat, Scott, if you can't speak, or I can allow your mic. I think I've just allowed you to speak, actually. It was leftover. Anyway, if anyone has a question online, maybe just put it in the chat, and then I can ask myself. Any other questions from the audience? For the Deslani.
Hi. Question for Dr. Seed. Given the restriction in possible blood flow and difficulties with nutrition, is there any room or thoughts or evidence about augmented nutrition in these kids, like combined enteral and IV feeds to try and make up for that deficit?
Yeah, I mean, it's interesting that you raised that, because I've wondered the same thing. Whether we should be using total parental nutrition, for example, in this sort of patients that have more unstable circulation or lower cardiac output during that initial period. But I guess that sort of thing comes with its own complications and risks. And I think what I am appreciating more is that these are sort of long-term modifications or adaptations to cardiovascular physiology that are likely to be present for long periods of time. And I don't know if it's going to be possible to do anything like that, parental nutrition. But it does make me think that there might be ways to modify our everyday management of congenital heart disease, where for example, in simpler lesions than Enstein anomaly, we still tolerate patients being in heart failure for prolonged periods of time before we try to deal with that. So patients with large VSDs, for example, typically still don't get operated until they've exhibited severe failure to thrive. And if that's the period, the maximal period of brain development that is occurring exactly during that episode, and we can now close VSDs pretty safely even in neonates, as we do in the setting of a co-arc VSD or a transposition or a pulmonary atresia, then maybe that would be something to consider.
And it makes you wonder if, similar to the new goal settings for the exercise capacity, whether these kids should have different nutrition goals in terms of their baseline. Is it like a chronically augmented nutrition baseline?
Right, and something that addresses the increased caloric uptake that's probably being driven by increased work of breathing and, as you say, impaired absorption of nutrition from the gut.
And I think the other thing I often think about with these babies and any baby really that stays in hospital for so long, after birth, is how we should really be sort of preempting this known nutritional deficit. I think Alex presented how long these babies were in hospital, and so you can imagine the negative effect that has on the parents and the mother's ability to actually express milk. And I often wonder whether or not antenatal expression of breast milk, just to get the colostrum, which is there, and get the going before the baby's born, so that it's available as the baby's on the NICU whilst the baby's critically ill. As the baby's probably in the post-operative period, but you have the availability for the best source of nutrition for those infants, to enable them to try and grow.
Yeah, I think that sort of thing has certainly been quite successful in the preterm population, with normal hearts, that increasing recognition of the benefits of breast milk, not just from a nutritional point of view, but also because it contains stem cells and all kinds of goodies that actually have been shown to improve brain development. Similarly, the neonatologists probably have quite a bit to teach us about developmentally appropriate care of newborns, with the attention they pay to the environment in which the patients are cared for, and in contrast to the sort of chaotic and noisy situation that we have in our own intensive care units.
Completely agree, and that kind of it follows on outside of hospital as well, doesn't it? Someone presented some data, I think earlier, about the discrepancies in relation to the parents. Was it I don't know whether it was the level of education and then the worst neurodevelopmental outcomes. And so you can imagine if the resources to try and improve neurodevelopmental outcomes in the community as well, specifically aimed at maybe the highest risk families, would be of benefit.
Yeah, and I think that's something that people are increasingly recognizing in the setting of perinatal brain injury, is that as you follow these patients up into older childhood, actually the impact of the brain injury becomes less and less important, and outcomes are essentially driven by socioeconomic factors. And so you can't even demonstrate an effect of a stroke in a older child with a fontan or something, because it's all related to their environment.
Again, maybe AI can help with that. And in those families, I mean, most people have smartphones these days, and they can access, create education very easily for them that they can access daily.
Yeah, I mean, people are certainly looking much more into ways to try and offset socioeconomic disadvantage, like whether that's actually financial support directly, or other sort of community support and family support for critical periods like pregnancy and neonatal period.
Anybody else have any questions from the floor? we finish there and we'll break. I'm not sure if are we meeting again at 3?
That's the plan, I think, with the session on 3D models and demonstration of cone repair. I see that Asami has made it back from the intensive care. And
well, sounds like a refreshment is not ready yet. So
okay.
Just wonder, should we do the demonstration first?
Yeah, we probably could, and then finish early.
Let's get to.
Okay. 1 minute.
Yeah, just give us one minute.
We have a plan. We're going to break now for some refreshments, which is just about to arrive, and then we'll restart with the surgical demonstration at 3 o'clock, so 10 minutes earlier than planned. Thank you.
Radar knows that sound means a Chewy delivery.
Perfect. You guys start.
All right. Recording?
Yeah, it is.
Okay. So here we have an Epstein heart. we can see that is an enlarged right ventricle compared with the size of the left ventricle. So this is descending, the posterior descending, and all of this is the right ventricle that's dilated. The right atrium is also a little bit dilated, and externally here we can see this thin area of the wall of the right ventricle. So we predict that the valve will be displaced down there. So this is the area that will need to be plicated during the procedure. So we will start. The patient is on bypass. We did the cardioplegia, and the heart is arrested. Towards the still some. The,
Yep.
Now the suture.
So that is
Yes,
like
you to wall,
Yep.
and then on the left side.
Let me know if it's too tight.
Yeah, it's good. I think this is good. Yes. That well exposed there.
Yeah,
for you?
this it must be a brand new. Okay. Which one's too tight?
No, I think it's good.
It's okay?
Yes, it's okay. And then we will evaluate the anatomy of the this heart. You can see the anterior leaflet here, and here we have the anterior papillary muscle. That's all stuck down there. We have the inferior or posterior or inferior leaflet here that's displaced, and we have the septal leaflet that's also severely displaced. So this is a very displaced valve, and this we can see the arterialized portion of the right ventricle that will later need to be plicated. We always start by dissecting the valve from the annulus in this position, like in the 12 position, 11 position.
Is it 11 o'clock? 11 o'clock or
11
12
o'clock, yes. 10 to 11 o'clock.
Okay.
That's the place that we know that the valve is not is free from the wall. And then we start dissecting all of the there, and then we start liberating the papillary muscles, the short papillary muscles here. Can you see a short one?
Can you see on the monitor?
Yeah.
Okay.
Then we cut it. You start releasing everything. So we keep as much tissue as possible from the anterior leaflet, even if there is some muscle attached to the muscles. We will cut to release, to free the valve from the wall. And here too, down there, can you see?
Yeah.
You need more light or not?
No, I think I'm fine.
For the videos?
Uh-huh.
I don't know. Do you want to?
So here we need to free. Can you see here?
Yeah. Yeah.
Maricor, I have a patient for Monday. And it's true.
All right, so we'll get to start. So this is the last session before we kind of conclude the symposium. And Luciana was supposed to um, sort of demonstrate the operation live, but they actually had to go back to their own town. So we actually did a recording this morning. So so Isra is going to give some presentation. Yeah, very quickly. And then we're going to show the video. But we want to make this as interactive as possible. So when you have questions, we're going to stop the video. We'll have a a discussion, then move on. So Isra.
Okay, so let's see, and I think you are, if you mind, no. Yeah. Okay, the last session of today. So what you are going to see is the work of the last 2 months, really in a rush, trying to achieve what we think we achieved today, but not really started 2 months ago. It started in 2007. So what you are going to see is like the tip of the iceberg of a work that Dr. Yu started here in Sick Kids in 2007 with the support of Glenn Van Artlen in that time. And they started printing in rigid materials. And this is what the 3D printing lab has become nowadays. So we are a group of 5, and you will see the amazing job that Brandon Peel, who is our engineer, has done with the help of Francesco Bertelli, who really increased the quality of our lab, incorporating the point of view of the surgeons. And because we didn't want to be isolated in printing, now we are also, you have seen the surgeons playing with the holograms and the virtual reality. And for that, Hannah joined the team. She's our engineer doing the computer-aided design and the programming of the virtual reality. And as you can see on the right panel, it's everybody who has contributed to the program. And we are not anymore a isolated program. Whatever you will see, it's the contribution of the whole team because we work in multimodality imaging. So we really thanks the effort and contribution from MRI, CT acquisition, all our technologists. And recently, we also have incorporated the work of our amazing sonographers who really bring the 3D printing to the reality, because this is what we do. We just incorporate the multimodality imaging. We are not a single isolated lab, because there is no single imaging modality that can achieve what we really need to achieve for printing. And we can get the aorta or the myocardium from CT or MRI, but we really need a 3D echo for evaluation of the valves. And with the support of our enthusiastic surgeons, we are now able to show the anatomy for virtual reality or mixed reality or in the computer, or we can bring the models. And what you see over there in the top right is the first models where it was a bit difficult to perform the surgery. But now, thanks to the amazing lab we have right now, we are the first center in the world who is able to produce silicon models, which is what you are going to see, which is really a milestone in the center. We don't really need to go outside and outsource what we do. And again, with the support of the surgeon, in this case of Dr. Vanderland, we are the first center able to do the hands-on surgical training. So it's a great opportunity for the new fellows to be able to perform the surgery. And these are some images of the last year. And I think the quality and excellence that the 3D printed lab has achieved, it's amazing, and the numbers talk by themselves. So we are providing models to 30 countries, and we have trained over that nearly 200 attendees. And this is the outstanding breakthrough, which is now we are able to do 3D printing or casting in silicon. And what you will see here is, as I said, the tip of the iceberg. because now we are able to incorporate valves, and what better condition than the Enstein to really demonstrate how to perform a cone repair. So please take a picture of this one if you want to join the next hands-on surgical training that in person we will do here in September. And we will go ahead now with the presentation of the surgery. And Dr. Yu, if you would mind to have a seat here as well.
So what we're going to do is in the middle of the screen, we'll show Dr. Da Silva's sort of a diagram of the steps of the cone procedure, and we'll show you the video. So Luciana is going to kind of go through that, and as I said, if you have a question, we'll stop the chat and then continue.
We predict that the valve will be displaced down there. So this is the area that we need to be placated during the procedure. We do regular incision with the right agent.
You try to identify the right coronary.
Yes, yes. So we usually we go parallel to the coronary artery, and we go all the way down towards the IVC here, more parallel to the. Can you see that?
Yeah. Just
through more the anterior wall here, just to show better, to expose better for the audience.
Which one's the type?
Right here, and here we have the anterior papillary muscle. That's all stuck down there. We have the inferior or posterior or inferior leaflet here that's displaced, and we have the sacral leaflet that's also severely displaced. So this is a very displaced valve, and this we can see the atrial.
Yeah, just the pickups is pointing towards the atrial portion of the ventricle, essentially Luciana is trying to get the sense how big this atrial portion is, and then so she's going to delaminate the leaflet.
At 10 to 11 o'clock, that's the place that we know that the valve is not is free from the wall. And then we start dissecting. Here is still the anterior leaflet. Looks like there is a trialized portion of the anterior leaflet here, because all of this is the anterior leaflet until there. So the inferior is going down there. So in the real life, most probably we would be able to delaminate here from the wall, like this. Yeah, see? There, and then we start liberating the papillary muscles, the short papillary muscles here. Can you see a short one?
Can you see on the monitor? Yeah. Okay.
Then we cut it. You start releasing everything. So we keep as much tissue as possible from the anterior leaflet, even if there is some muscle attached to the leaflet. So we go further. So we need to be careful here, not to go in the coronary artery. That's in the tricuspid valve annulus. We can see from outside there, right? Yeah, the coronary artery is there.
I have a question to you, Sami. Here that do you really go to deep to the myocardium like this? So I was quite impressed that the so-called delamination process was really coming into the myocardium.
Yeah, so this one I found this little quite aggressive, I have to say. I usually leave a little bit of leaflet tissue on the annulus, but if you go down below the annulus, obviously so here you can probably keep playing that. So there's a kind of leaflet that becomes a muscle with continuity. So that's what she's cutting quite aggressively. And so this is a good demonstration that you have a lot of sort of a small papillary muscle. So what she's doing that is because there's a possibility of transferring those small papillary muscle to this new place, she's cutting with some margin of muscle so that she can use those as a new sort of supporting structure. But the important thing is that it's really cutting everything until this anterior posterior leaflet is becoming completely immobile. But at the annual level, I was surprised that she is quite aggressive. Let's keep going. Any question from the floor? Maybe you can skip a little bit. So essentially, so she started from sort of 11 o'clock, if this is a clock, and then going clockwise all the way down to the septal leaflet. And then eventually she's go counterclockwise to get all the anterior leaflet mobilized as well. Maybe we can skip all the way.
Is there any reason why the she starts 11 o'clock?
So she explains that 11 o'clock area is the one that's free floating anterior leaflet. There's no subvalvular apparatus on the back. Then you can look down and then start cutting those undelaminated structure. So if you go clockwise down to the posterior leaflet, you can see there's dense structure that you have to cut it. But you can see this 11 o'clock, 10 o'clock is free from those tissues. So you can see that she's going counterclockwise. And can you stop there? Yeah. So what she's holding is the resected edge of the septal leaflet, and obviously this patient have okay size septal leaflet that you can use, but sometimes it's just remnant, and then she's deciding whether or not detach the anterior leaflet completely and then connect to this one, or leave the anterior leaflet attachment, and so on. So obviously, potential case here of this operation is treatment around the septal leaflet, because sometimes it's deficient.
Increase the excursion. So you keep the distal portion there. We can keep it there. Hold the
support from the annulus, but you don't do that.
With the delamination of the septal leaflet,
So
I guess you're too low down on the septum to worry about the right bundle.
Yeah, so obviously you may, if you go too deep, then you may, injure the conduction, but we just follow the bottom of the leaflet, not to the muscle. So compared to, let's say, along the posterior leaflet where you want to cut some muscle with the leaflet, the septal leaflet area, we have to be careful.
So that would be the bottom, right? It's not,
yeah. But like this papillary muscle here, I think we prevent a little bit the excursion. So usually what we do, we do not cut it from the wall, but we delaminate a little bit more here. Yeah, hold there.
Can you see on the video?
Yes. Can you see it?
Yes. Yeah.
And then we move a little bit further to create more mobility to the valve.
Okay.
So we move.
So just like you did for the septal leaflet, you're just extending?
Yes. The septal anterior. So let's see from inside now.
Let's see from the RV. Okay, let's see.
Now, this papillary muscle there.
This needs to go, no?
Yeah, it needs to be cut because it's holding the leaflet. And if you could not cut it, you would delaminate the leaflet to come back down there. Okay, but this you can cut.
What about this? This is
no, this is the one that we extended already. So to prevent bulging of the anterior wall, if you are worried that you detach it a lot there, then you can create some suture here.
So this is not, are you plicating?
This is not the plication,
no. Okay.
No. This just to keep the same, some sutures like that. So if you think there are more papillary muscles.
And those are both focus on this rotation, but can you easily tell by the pre-op echo, or you have to actually look
usually
inside?
We need to look inside,
yeah.
yes, look inside. Yeah. So this would be like, we need to detach a little bit more here. Okay. And then we usually at this point we would go for the plication of the right ventricle. Then we need to suture inside there. Can you take out the light, please, in the normal heart? So
you see it?
Yeah, I can see there. Can you see?
So you started above the original attachment?
Yes.
Okay. Yeah. So here, just shown in this diagram as well, but essentially she's plicating the atrial portion of the right ventricle. One stitch before that, I didn't realize that they do this, but when they take down the end of the anterior leaflet or posterior leaflet, they also approximate those areas to prevent dilatation. But this is the area that she's starting a suture from the top of the hinge of the septal leaflet or the posterior leaflet, and then coming up to the through annulus to plicate the right ventricle, and then also plicate part of the trachea valve annulus. Yeah, can you stop there? Yeah, the first stitch is the area that so Luciana took down the end of the anterior leaflet with some additional papillary muscle, and then also from the posterior leaflet. So she explains that sometimes those areas can also dilate after the cone. So that's what kind of prevention stitch to put it together. Let's keep going. Did you take that
Yes.
as a suture line?
Yes.
Okay.
In the septal area here, no. In the septal area, you follow the.
Yeah, there is nothing, right?
Yes. Here you can see the division between the thin area and the strong area. So this is normal. This is septal septal area that will not never be thin because of the interaction with the left ventricle. So here we application contractility.
Eliminate.
Yes. You can choose also instead of doing. Like I said,
You can skip a little bit. So,
the
so essentially, these sutures, as shown in the diagram, so 2 layers to make sure this one doesn't dehisce, and then come up to the true tragus valve annulus, and then it should be lateral to the coronary sinus. They explained that it's sometimes in a really big tragus valve annulus, they do plication of the annulus here, and then 1 or 2 anterior around the 10, 11 o'clock. But this is the main sort of a both right ventricle application and annular application. Yeah. So much shallower stitch.
And then we stop
Okay.
here.
Are you above the annulus? Or?
Yeah, just a minute. Oops.
It's okay. It's okay.
Pretend that we that not broke like that. It's not. Let's see. Let me go again.
So you go just above the annulus, shallow stitch, and then tie.
Yes.
Okay.
That's what I want to explain to you. In terms of the sutures here. You just do not want like to.
This is all annulus.
Yes,
Okay.
the annulus.
Side.
Yeah, sometimes we do like here, here, and here.
Okay.
Yeah.
The first one is area application.
Yeah. So the goal here is like not to kink the coronary. Usually.
Amount of indentation.
So essentially, we spend a lot of time on this corner. So you can see that the right coronary artery is just outside, and sometimes this plication stitch causes the kinking of the right coronary. Can you stop there for a second? So for that reason, they sometimes completely free up the right coronary and kind of make it away from the atrioventricular groove and then carry on. But as I mentioned, so this is a very important area of atrialized portion plication and annular plication.
So it's a little bit different. Okay. And then we start reconstructing the corner. Okay.
Moving.
So now we need to suture this tissue here. So here I think we can cut that papillary muscle there, down there, this one here.
I guess those kind of hanging structure behind the cone doesn't really matter, right?
Yeah, yeah. And then we suture like this. To this sacral area there, here.
Yeah, you have more.
So the
So then we need to see the position.
Luciana said that here you're going to use that two fingers to size the annulus and the orifice. And then do you agree with that?
A bunch of fibers.
Yeah.
Well, when you do hundreds of cones, I think 2-finger or finger measurement might be enough, but
yeah. So the reason why I'm asking is that would you be interested in predefine the size of the ring for the patient size instead of the heart size? And then we can make print the one ring for you, and then to size intraoperatively.
yeah, so I think can you see it on the monitor? The annulus that we are plicating to, we actually don't have defined annulus, like proper annulus size. In fact, the top of the cone size doesn't really matter because what's creating the stenosis is it's the bottom. Again, Luciana measured it with 2 fingers, and then the small size patient is 1 finger. But so I don't know. It's a scientific ways to measure the proper orifice. But what I found is that because this is a cone, the top part is really kind of accommodating the flow, but the gradient actually happened at the bottom. And then bottom, it's not just a orifice towards the right ventricular tract, but those fenestration all act as an inflow. So that's why not many patients actually have gradient, pressure gradient in the inflow. So to answer your question, actually no one knows the proper side in my mind. Keep going.
So here's the
So in the normal setting, you prefer interrupted here or?
No, usually I do
locked.
Okay. Unless I have any doubt how it would work.
Yeah. So now it's starting the process of making a cone, and usually started with the corner between the anterior leaflet and then septal leaflet. And this is kind of a, I would say, fun part to create sort of a crafting stuff, because you can use this remnant of septal leaflet in any way to make this, to fill the gap
And then at this point we make a decision if we
in
need to
this
decrease all
corner.
the animals. Sometimes, and then, like I said, we can decrease here
Yeah.
and this area here.
How do you titrate? How do you decide the?
My 2 fingers here.
That's it?
Yeah. Here you need to make a decision where to